It's my great pleasure to announce the next speaker, who will be Professor Risa Pretorius from South Africa, Stellenbosch University. Yeah, and she's online. She will refer on tiny blood clots and endothelial dysfunction. Thank you for joining us.
Thank you very much, Kennedy. I presume everyone can hear me. I'm just going to continue then. So hello, everyone. Today I will be sharing with you our latest research on clotting pathologies, and I will spotlight our recent findings in COVID-19 as well as long COVID. There are just some disclosures that I would like to share. I've got various funding from Polybio Research Foundation, Bellevue Research Foundation, and our South African National Research Foundation, and the Medical Research Council in South Africa, as well as the Colonel's Funding Initiative. I do also want to acknowledge my various research collaborators. This is obviously just a very shortened list, and I'm mainly focusing on my South African collaborators, and also Professor Douglas B. Kell, who's from the University of Liverpool, and we have been doing research since 2011. Various clinicians, also a team of biochemists, a team of data scientists, my PhD students, and my laboratory manager, Chantal Finter. I would also just like to note that Mediclinic Private Clinical Hospital approved sample collection at their facilities, and this is the data that I'm going to show today. And we also received ethics from both our Stellenbosch Ethics Committee as well as Mediclinic. My lab and our collaborators from various labs over the world have been identifying inflammatory molecules in circulation that might be involved in and drive pathological clotting. And we have also focused our research endeavors on studying the effects of increased circulating inflammatory molecules and how they interact with cells of the hematological system. We focus in particular on platelets and red blood cells, as well as on the clotting protein fibrinogen. We are also interested in identifying novel inflammatory molecules that might play a role in the persistent symptoms of long COVID. Over the years, we have published numerous papers that show the importance of inflammatory molecules in circulation and their role in abnormal blood clotting. I am specifically interested in platelet signaling and the role in abnormal clotting. Platelets, as you know, in circulation play a critical role in healthy blood clotting. However, they can become overstimulated and can drive pathological blood clotting if there are inflammatory molecules in circulation. This can also happen in the presence of viral infections, where platelets can act as important signaling entities. There is also a complex relationship between receptors on platelets and endothelial cells where circulating inflammatory molecules may bind to. As we now know, damaged endothelial cells and platelet hyperactivation are central pathologies also in long COVID. Our research group have therefore showed these pathologies in acute COVID and also long COVID, and also conditions like ME/CFS. In the context of COVID-19, platelets are therefore central in immune activation and general coagulation pathology, and they can form various complexes and obviously also within cells. In that case, it is known as platelet clumping. We are also interested in pathological blood clotting, as I mentioned, involving the main clotting protein fibrinogen, which is a soluble protein in circulation when you are healthy. If you focus your attention to the three cartoons shown here, on the left, cartoon A is a healthy protein structure, which has many alpha coils and few beta sheets. However, in the presence of inflammation, oxidative stress, and circulating inflammatory molecules, this structure changes where the inflammatory molecules, also spike protein, may bind to the fibrinogen proteins, shown in cartoon B. Such direct protein-protein interactions may cause the alpha coils to untwist into beta sheets, as seen in C in the cartoon on the far right. We suggest that fibrinogen molecules then have a fibrinoloid structure, and we have shown this with various amyloid protein markers like thioflavin T and amitrackers, We call these fibrinolytic plasma proteins, microclots. We have looked at blood clotting in acute COVID right in the beginning of the pandemic using scanning electron microscopy. We found that platelets are damaged and clump together and attach to red blood cells. The clotting proteins that is supposed to be soluble also form spontaneous microclots. In the micrographs on the far left, you can see platelets that are hyperactivated. Note the yellow arrows. In the middle are micrographs where platelets are attached to red blood cells. Note the white arrows. On the far right, you will see micrographs of spontaneously formed microclots that even glue together red blood cells. Note the blue arrows. Now, with this ultrastructural pathology in mind, we took platelet-poor plasma and exposed it to our fluorescent marker, theoflavin T, that I just talked about in the previous slide. This binds to open hydrophobic areas in protein that are damaged. This marker was first used to identify amyloid protein in brains of Alzheimer's disease patients. However, in 2016, our research group discovered that theoflavin T also binds to misfolded fibrinogen and fibrin proteins during pathological blood clotting. Here you can see the differences in platelet-poor plasma structure in acute COVID-19 patients during the acute infection, where we compare plasma smears of these patients to that of healthy participants, as well as to patients with diabetes. Here we can see microclot formation demarcated as the green signal from theoflavin T, our marker of misfolded protein. We found small areas of nearly abnormal detectable clotlets present in plasma of healthy individuals, as you would expect, and this can be seen in micrographs on the far left. More abnormal microclots were noted in plasma of individuals with diabetes. What was, however, quite significant to us was the extent of the abnormal microclots in acute COVID-19 plasma, as you can see in the far right plate. Also note the scale bar of 10 micrometers at the bottom of the micrographs. Here are examples of platelet hyperactivation during acute COVID-19. As microscopy results are difficult to quantify, we therefore suggested at that stage a microclot and platelet grading system based on various stages of severity of both microclot activation and based on the various stages of platelet activation. Here are examples of our platelet grading system. In our experiments, hematocrit samples are exposed to two fluorescent platelet markers. The one is CD62P, which is the pinkish signal, and that is a marker for P-selectin. This marker is either, the molecule is either inside the platelets or on the membrane, or it can be found as a soluble marker. Here we show where it is found on the membrane of the platelets and where it acts as an adhesion receptor. We also use PAC1, which is the green signal that identifies platelets through marking of the glycoprotein 2-beta 3-alpha, which is found only on platelet membranes. The micrograph plate on the left and the top row shows examples of platelets from healthy or control samples. There obviously minimally activated platelets are noted. This we demarcated to stage 1. The plate shows increased platelet spreading and the beginning of clumping. The micrograph plate on the right shows platelet clumping, and at the bottom, the most severe examples of these platelet clumps. Here is our microclot grading system shown on the left plate. Stages 1 and 2 demarcates minimal microclot formation that you would typically find in a healthy individual. We also suggest that the various stages can be used in a numerical scoring system that might be used in both acute COVID-19 and long COVID patients. Just for comparison, I just again added the examples of how microclots look like in type 2 diabetes. Now, with this knowledge in mind, we also looked closely at spike protein. In 2021, we looked at the effects of addition of the S1 of the spike protein on clotting when we added it to healthy blood samples. Here you can see how it also causes microclot formation in the green signal, as you can see in the slides on the left, B, and D. And A and C is the original plasma, which we then expose to spike protein. And you can also, in the pinkish signal, you can see that it also activated platelets from healthy individuals. If you look at these slides, we also looked at scanning electron microscopy. And on the left, you could see red blood cells and also platelets. And you can also see how in the presence of spike protein, the S1, as I mentioned, the significant induction of these activated platelets and microclots are noted. These clotting pathologies with microclots are seen in these micrographs. And then we also thought, let's initiate a microfluidics experiment, which can be seen in the plate on the right. Healthy plasma do not have much microclots, as you would expect. However, in both acute COVID-19, which in this case was the earlier Delta variant, significant clots are seen in our fluidic system. And when we added spike protein, we could induce similar structured microclots. We are also very happy to report that the microfluidic system that was developed by Dr. Martin Crater at the Max Planck Institute also reported these similar type of microclots in their fluidic system. In fact, I'm very happy to report that his instrument was actually shipped to our lab earlier this year, and we are doing some collaborative research with Martin on the structures of the microclots in his system with our population in South Africa. Recently, also together with various collaborators from the USA, we looked at microclots and platelets from the more virulent Beta and Delta variants, and we compared it to Omicron. Here you can see, as one would expect, because Omicron is not such a severe disease, Omicron individuals in the acute phase have much less microclot formation than with the earlier Beta and Delta variants. However, if we look at platelets, we could not really see a difference between the platelet hyperactivation. Omicron seems to also cause significant platelet hyperactivation. Then obviously we know that long COVID is a massive dilemma. And we looked at blood samples from patients soon after we realized in end of 2020 already that there might be a dilemma with disease in long COVID patients. We also soon realized that there are persistent microclots and widespread endothelial damage as well as platelet hyperactivation in these individuals too. And we believe that these pathologies may be central in causing the widespread symptoms in these patients. And it may eventually lead to conditions like tissue hypoxia that may result in many of the, or might be a causative reason for many of the symptoms that the patients have. Here is just how we saw some of the microclots and platelets in long COVID. As you could see, significant microclot formation as well as significant platelet hyperactivation. We also initiated a South African long COVID registry in 2021. And here you can just see some of the symptoms as well as the comorbidities. And in our South African population, we don't have results that are dissimilar to the rest of the world. We see the same trends with brain fog, concentration issues, forgetfulness, constant fatigue as some of the main complaints of our patients, and our comorbidities high on our list of people with previous comorbidities, high blood pressure, high cholesterol, rheumatoid arthritis type conditions. We also planned an experiment where we looked at proteomics of healthy plasma and type 2 diabetes, acute COVID-19 and long COVID, and our healthy and type 2 diabetes samples were stored. So we know that they did not have any possibility to have been exposed to spike protein. And we also added the diabetes samples, obviously, because we know people suffering from diabetes are more prone to severe COVID-19 symptoms. For our proteomics analysis, we prepared platelet-poor plasma from citrated blood. And as you would, typical experiment, we needed to have a digestion step, which is trypsin. To our surprise, we found a visible deposit at the bottom of the Eppendorf in the acute COVID-19 and long COVID samples, but not in the diabetes samples and also not in our healthy samples. Plasma proteins, therefore, were fully digested in controls in diabetes, and this suggested that trypsin could degrade all of those proteins, but not the proteins that are present in the COVID and long COVID samples. For our proteomics, we then developed a second trypsin digestion protocol, and then we could, fortunately, solubilize digest the pellets. We then looked at the various proteins after the second trypsin digestion step, where we could digest all of our microclots, and we detected various inflammatory molecules that were substantially increased inside the now digested microclots of patients with acute COVID as well as long COVID, versus the equivalent volume of fully digested fluid of the controls in diabetes samples. Obviously, some of the molecules that we would expect and that we obviously found were some of the fibrinogen molecules that we would expect there, von Willebrand factor. But of particular interest was a substantial increase of alpha-2 antiplasmin. And that gave us quite an interesting phenomenon if we look at the clotting cascade. So as I mentioned, alpha-2 antiplasmin was significantly increased, and the reason why it's so interesting for us is the fact that alpha-2 antiplasmin is a molecule that prevents clot breakdown, and it interferes with the fibrinolytic process. And that might give us some information on why the actual little microclots that we see in circulation of these individuals simply do not break down. What our information also gave us, our proteomics analysis also gave us, is an idea that many of the molecules that's typically in soluble form and that ELISA protocols or experiments were supposed to pick up will probably not be picked up because they're not in soluble form. They are actually entrapped inside the microclots. We also completed a larger proteomic study, and all our results were confirmed. However, we were also in this second publication that we published last year, surprised to find a significant presence of antibodies entrapped inside the microclots, which gives us quite nice information about the possibility of a significant immune activation. Our findings, however, mainly from this proteomics analysis, suggest that hypercoagulation and vascular damage are key role players causing the various symptoms. Following from this research, we also revisited our stored sample, and we looked at the inflammatory molecules in the soluble fraction of the blood to see if there's possibly a way to use some of these molecules. We looked at von Willebrand factor, platelet factor 4, serum amyloid A, as well as alpha-2 antiplasmin, and we also looked at E-selectin and PCAM. And those two are obviously endothelial markers. Here you can see just some of our results from the study where these molecules are significantly increased in alpha-2 antiplasmin, obviously our main interesting molecule that was significantly increased in the soluble fraction as well. We also looked at ME/CFS because we know it's related to long COVID as a post-viral disease. To our surprise, or perhaps not surprise, I think we thought we would be getting these results, but we also found microclots in platelet-poor plasma from ME/CFS patients and significant platelet hyperactivation. What was, however, interesting for us is the fact that ME/CFS microclots are not so large in size as we found in long COVID and acute COVID. But that is not surprising because we think that the reason for the large clots is basically the presence of spike protein as well. We also found a significant number of endothelial debris in our platelet-poor plasma in both ME/CFS and long COVID. And this is unpublished research where we added E-selectin as our marker. And here you could see that there are these endothelial debris present and floating around in the platelet-poor plasma. And here you could see our control. Looks obviously we don't expect to have endothelial damage in controls. Long COVID, we do have lots of these debris lying around. And we found this one big piece of endothelial damage mark with E-selectin in our ME/CFS samples. Lots more, but this is just one of the nice pictures that I would like to share with you. Then the question arises, We have now looked at these samples, platelet poor plasma and platelets, using microscopy, but is there a place for flow cytometry? And recently, with the help of various funders, we acquired an imaging flow cytometer. And here you could see some of our very preliminary results, where we indeed found these microclots, and we can now, with this methodology, with the imaging flow cytometer, count the clots and work out the area ranges of the sizes within controls and various patient groups. And this is just some of our latest research. This paper is in preprint. We also looked at clinician-initiated treatment regimes, and this is some of our platelet data. In this case, we looked at 91 patients from our clinical collaborator who treated long COVID patients that he identified as having clotting pathology with anticoagulant regimes. So just a disclaimer, I'm not a clinician, so I can't go much into what he used and why he used it, but it's a triple anticoagulation therapy. And these patients, 80% of them, and it was obviously just a snapshot, reported that most of the most prevailing symptoms were much better after treatment. And here you could just see the patients filled in a PGIC scoring where they themselves report whether they feel better or not. And the average of 80% was reached, where 80% of the individuals that we followed said that they felt better. Interesting for us, if the patient said that they felt better and the symptoms was not so severe, their microclots as well as their platelets were significantly reduced. The microclot formation and platelets were not as hyperactivated. So this gave us quite a nice result where we looked at the PGIC score before and after treatment, and when patients say they felt better, they actually indeed looked better as well under the microscope. So here's just an overview of what our thoughts are. So just to bring together some of the major elements of what we have seen. So we believe that, as we all do, long COVID is an extremely complex disease where ischemia, hyperperfusion injury might be driven by platelet hyperactivation, fibrin microclots, circulating inflammatory molecules, as well as antibodies and autoantibodies. And ultimately, these pathologies suggest that long COVID might be, in fact, a thrombotic endothelitis that we should focus on and try to treat, as well as looking at viral persistence and all of the other immune-related issues that these patients might have. I wish to also turn your attention to the February 2022 US government document, the GAO, where microclot presence, viral persistence, autoantibodies, together with organ damage, were recognized as central pathologies to look into in finding answers to long COVID. At the US National Academies of Sciences meeting earlier this month, where I was also giving a presentation, the Chief Medical Officer of the FDA again referred to this document and showed this specific slide as well, suggesting that this should still be a key focus in searching for answers for long COVID. Again, microclots were noted as a central pathology to look into. I'm very happy to report that our work was also featured in Science as well as in Nature, and the beginning of the year also in National Geographic. So just to end off this presentation, I have some take-home messages from what we have found. And we believe that the relevance of receptor inflammatory marker interactions, and including in this is also autoimmune reactions, may be driving the disease pathology. And there's also a relevance of direct protein interactions in clotting pathologies in long COVID. And perhaps there's a place for novel methods in the diagnosing of well-known as well as new diseases like long COVID. And here I would like to include the use of fluorescence microscopy, perhaps an automated system, proteomics, which might not be a point of care, obviously, as we know it's difficult to do, but it might give us some more information. And then definitely a place for imaging and typical normal flow cytometry. And then there might even be a place for novel point of care technologies to study the flow and the clotting propensity in individuals with these type of diseases. Thank you very much. And thank you very much again for asking me to present our results at your wonderful meeting.
Well, thank you very much for this outstanding talk on platelets and the consequences. Are there questions? Yes, please.
Thank you very much for this very interesting presentation. So my question is if these changes are really COVID specific, or we can translate maybe this knowledge also to other infection diseases. Thank you very much.
Yeah, thank you very much for this question. I totally agree with you. This got a lot of. Sorry, I'm hearing feedback. So just, are you hearing feedback as well? Is it okay now? Okay, so I think it's a very valid question that you're asking here. I think clotting pathologies and platelet hyperactivation and microclot formation is not only a phenomenon that is true to long COVID. What was so striking for me was the size and the sheer volume of the microclots, and that might be related to the spike protein. And then platelet hyperactivation as well. I've never seen the amount of platelet hyperactivation in any other disease. As I mentioned with ME/CFS, we've noted microclot formation there as well as platelet hyperactivation. But those patients were collected, samples were collected, we know they did not have COVID. So we do see microclot formation in these conditions as well. Interestingly, previously, long before COVID, we actually looked at LPSs and LTAs from bacteria, and we could actually induce microclot formation and platelet hyperactivation using bacterial inflammagens. So I think it is perhaps at this stage, and perhaps COVID opened up the scenario for us to further look at how clotting pathologies might look like in various infectious diseases. And it might give us an idea if there's EBV or any other of the virus bacteria that is known to be involved in conditions like ME/CFS. That might give us a place to search for treatments if we have widespread clotting and platelet pathology, which will eventually result in a thrombotic endothelitis in these individuals too.
Can I ask another question? It's actually well known that viruses can host in platelets and reproduce themselves in this. Is this known for COVID?
We were actually just having a discussion last night with a few of our collaborators in the US from Harvard and from Yale, and in our meetings. And we have also thought that this might be a very important avenue to look into. I myself have not found, I have not looked whether platelets might harbor the virus or spike protein inside them, but it's probably a really good research question. And I think there are some of the researchers in our wider community of long COVID that are planning to look into this. Also, perhaps in looking into the megakaryocytes, what's happening with viral spike protein, virus itself, inside the megakaryocytes and perhaps inside the bone marrow. So I haven't looked, but I think it's really a good idea to look.
Well, if there are no further questions, thank you very much again. Have a good day in South Africa.
Thank you. Thank you.